Good evening, everyone. Welcome to AONM's third in our series on the cranial connection. We have Dr. Iain Smith with us again for a second time, as his talk last week was so very popular, and he does have more to add to it. He has some cases that we didn't have time for last week, and there were a lot of questions, so we'll leave lots of time for those as well. As I'm sure you know, he's a doctor of chiropractic and also a craniopath. He he obtained his doctor of chiropractic in Australia and the USA, and then moved to the United Kingdom 2 decades ago and has been practicing ever since in Shropshire. So what we'll do is he'll first of all present the 3 cases that he has, and then after about 30 minutes, we will switch to questions. So please put any questions you have in either the Q&A or the chat. And very much looking forward to part 2, Dr. Smith. Thank you.
Thank you, Julian. Right, sorry. So last week we got through the end of the management algorithm, so to speak, but we didn't manage to really get to some cases, and I had hoped to run through, and Julian has asked me to come back and present those. So we'll take a few minutes to pop through then, and then hopefully answer should you have any. So this first case study is a young lad who came to see me not that long ago, and he has a diagnosis of HEDS. He's 9 years old. He had a day about 12 months ago when he was bouncing around a little bit more active than usual and had a sudden onset of severe headache that he described at the time as being around a 10 out of 10 with associated neck pain, CCJ pain. Now, his mother is a PT. She's quite concerned, so she had some investigations done. And as time went on, he started to develop other problems, other symptoms that went with this particularly severe headache that he described as being a 5 out of 10 to a 10 out of 10 at any given moment. He managed to modify his behavior a little bit. So he spent, over the months, he learned to control what he was doing to the point where he had less episodes with the 10 out of 10 type pain. But simple things like running across the backyard 15 or 20 yards, and he would wake up on the ground. He'd have a syncopal episode. He was diagnosed with POTS. He had visual blurring, visual disturbance. And more progressively as time went on, and of great concern to his family, was his cognitive abilities seemed to be deteriorating significantly. And he's a very bright student, a very bright young man who was really struggling to process information and to complete schoolwork, most of which is, of course, online at the moment. He was clearly distressed when he came to see me, in the respect that he just couldn't be upright for more than 5 minutes at a time. And Mum told me that for some months, although they tried to go, the family enjoyed walking in the country, they wouldn't get past the front gate and they'd have to turn back with him. So his routine for exercise was literally to get up and walk around the house for 5 minutes and then go and lay down again. He presented with right-sided hemiparesis, which is weakness down the one side of the body. I noticed when we were examining him, he had a very mild head tremor, and also his his muscle responses, particularly in the right upper quarter, were quite tremulous when he would try to initiate them. His coordination was off, just general gait and station was not particularly good. Transitioning from getting up and down off the table was quite awkward for him. He had a swallowing reflex issue now. This had been identified by a dentist in his home country, and he was undergoing some restorative or jaw orthopedic work when he came to see me. And he had a congenitally short frenulum that had been surgically corrected. As I mentioned, he had a diagnosis of HEDS. So here's a lateral radiograph of him. He's certainly got plenty of lordosis in his neck, but we can see there's an opening of the periodont of the atlantodental interspace here. We can see a light out appliance in the bottom jaw. After that, nothing too exciting. A bit of retrolisthesis there, maybe. When we look here, we can see there's some unleveling, and there's quite a lot of rotation of the second cervical vertebra here. You may remember this young man's scans made up part of our presentation, which we'll get to in a second, from last week. And we can see here that the periodontoid space is somewhat widened on the left side compared to the right side. Frontal projection, lots of teeth in the way, but we can still make out the atlas there, and there's a little bit of a very mild sort of lateral curvature, sigmoid in presentation. Horizontal film, again, nothing too exciting there. This makes up part of the basic upper cervical series that we take for analysis. You might remember these two images. These were part of our discussion on dentate ligament distortion last week. You can see this is an upright CT scan. There's a significant counter rotation of C2 relative to C1. And when we talked about the neurovascular structures in this region that are likely to be under tension, there are several. Obviously, the brainstem, the posterior emissary return pathways here, internal jugular veins sit right about there. So we can infer from this that there's potential for craniospinal hydrodynamic issues. And again, we can see here that the dens is not midline relative to the lateral masses of C1. It is over to the right slightly. So rolling on from that, this particular scan was done also in cervical rotation, and I've taken the liberty to color the lateral masses in a little bit just to make them a bit more obvious. But this is in left rotation, and we can see there's quite a lot of rotation here. And this, as we cut down through the slices, we now, this is the atlas here, it's outline, anterior arch lateral mass, transverse process, transverse foramen. But as I come down here, this is now the second cervical vertebra, the superior articular surface of it. And we can see that there's very, very little overlap of these two structures. So as you come down, you can see again that it's barely touching here, barely touching there. So this is more or less what I refer to as dropping off. The atlas is rotating far enough that it's not keeping contact with the second cervical vertebra below it. When you look at the left side here, we can see there's still good contact maintained between C1 and C2. When we rotate in the opposite direction, so the head's turning right now, again, lateral masses in blue. As we come down, we're now starting to see the articular surface of C2. A little more contact on this side. Not a huge amount, but certainly more than when we were turning to the left. And again, obviously, quite a bit of contact here on the right-hand side. This is his prenasium that we looked at before. Again, you can see the upper thoracic and lower cervical spine coming in under the head in a slight curve. If you kind of hallucinate, you'll you'll see that shadow there. And here is his post X-ray. You'll notice that the upper thoracic spine is now more centralized to the central axis of the cranial base, upper cervical spine. So what happened? Well, immediately post-correction, his right-sided hemiparesis went away. The four-quadrant weakness that we talked about last week is essentially a loss of hip flexor control and also grip strength in opposition. Again, that resolved instantly post-correction. Over the next 9 days, he stayed in town and we monitored this. The neck pain, his cognitive function, his issues with memory retention or loss, the visual disturbances, his gait and station coordination disturbances, the resting head tremor, his POTS signs and symptoms, they all progressively improved and resolved over the 9 days that followed. His ability to stand up, that improved quite quickly in the respect that this was an unintentional test, but the family was staying in a rather nice local self-contained unit out in the country. And they went for a little bit of a walk and got lost. On day 4, they were gone for an hour and he managed to tolerate that quite fine without any ill effects other than the fact that his legs were aching because he hadn't been on them that long, in 12 months. On day 8, he apparently walked into the kitchen in the self-contained unit that they were in and confessed that his headache had stopped, that he had no pain in his head for the first time in the 51 weeks that had gone before. So a very happy outcome for the family. I've been in touch with Mum now that they've gone back to their country of origin, and she's telling me that he is thriving with his schoolwork and doing very well, but also making sure that he doesn't upset things. And we'll reassess probably in a few months or when we have an opportunity if things improve on an international situation that we have right now. That's case 1. Case 2. Case 2, this was a couple of years ago, and I presented this one to our group in London back in late 19 to try and get across a point. In fact, there's a couple here that were in that presentation. And this young lady came to see me. She had a 5-year history of pretty stiff, sore neck. She'd been involved in a very nasty car accident 5 years before. She sustained life-threatening injuries, fractured lumbar spine that required surgical stabilization. She had a kidney removed because they couldn't save it, grade 3 for spleen injury, and ruptured diaphragm, broken ribs. She had an awful lot going on at the time. But understandably, that was addressed. Having said that, nobody really paid much attention to the cervical spine, I guess, because that wasn't a primary area of symptomatology or priority at that point. When she came to see me, this had progressed to a 12-month history of constant frontal headache. And she was describing it as being pretty much a 9 out of 10, and at times it would drop down to about a 6, but it was quite intense and unforgiving. She had dizziness and considerable sleep disturbance to go with it. I remember we looked at this set of images in the last PowerPoint presentation that we gave. And when you look at this, we can see several signs of laxity and ligament injury on the lateral x-rays here. We've got a slightly widening ADI. It's still within tolerance, but there's a shadow there. Interspinous fanning, which tends to suggest laxity of the interspinous ligament and capsular ligament complexes here, hypolordosis. And when we go into flexion, the atlantodental interspace opens up a little bit, and also we are going beyond our 18 degrees as being considered the upper limit of normal here. We can also see that there is stair stepping. The vertebral bodies are sliding anteriorly over each other, more or less through the cervical spine. When we go into extension, we see again that we are getting an angle that's in excess of the upper limit of normal, according to Henderson's criteria, of 55 degrees. And the vertebral bodies then start to realign, and some of them retroflex. So we have these upper two segments here, upper two discs, where we're getting translation, which would indicate subaxial element, subaxial instability. I haven't put the Harris measurements in here, but the Harris measurement is an indicator of basically we want to know that the clivus here, the basion relative to the axis or odontoid line here stays relatively consistent. And when you tip your head forward, the skull should more or less pivot over the tip of the dens. It shouldn't be translation forwards and backwards. So when we have excess of 2 millimeters or so, from flexion through to extension, then this is considered to be a marker of possible CCI as well. So we have hypermobility. We have some evidence of atlantoaxial instability, subaxial instability, and possibly some CCI. This is her upright MRI. The upper limits for normal, as you may remember from Professor Smith's discussion a couple of weeks back, is considered to be 35 degrees of rotation. So we have on right rotation, we're up around 37.5. On left rotation, we're over 40 degrees, which is, again, out of range. This is, again, we did look at this one. This was the case that had a mild cranial base asymmetry in that the condyles, the occipital condyle itself is offset, which gives us the perception of considerable rotation of the atlas relative to the central skull line here. But as I pointed out last week, this is there's not 8 degrees of rotation in this. This is an offset occipital condyle, so be mindful of that. Anybody out there who's working in the field, just to be aware that these do show up, and you don't want to try and take 8 degrees of rotation out of that COC1. Again, when we're talking hypermobility situation, we often see this enhanced posterior emissary return pathway. Again, we've got some quite large veins here coming out through the base of the skull. So what happened with this young lady? Well, we adjusted her atlas, and she came back the following day and reported that she had no significant signs or symptoms, which is kind of nice. At 2 weeks, we followed up again. At 6 weeks and at 3 months, she still reported that she had no headaches, no significant signs or symptoms. She had gone back to university and started her second year of education and joined the rowing team. So a positive outcome in that situation. Case study 3. Again, this is a female, 39-year-old female with a 9-year history of a plethora of signs and symptoms that we covered in Craniocervical Syndrome last week. The onset of neck pain, extreme fatigue, dizzy spells. This started the day after she was involved in a head-on collision with a coach, a tourist bus, whilst on holiday in Europe. And it's progressively gotten worse. She got to the point where she was having trouble breathing. Her cognitive function had deteriorated significantly to the point where she was not really able to focus on tasks. And if she was up for about 3 to 4 hours, she would have to go and lay down before the room would start spinning, and she would just not be able to function. She'd been diagnosed with chronic fatigue, and also had a diagnosis of Lyme disease, which she was having treated at the time in a clinic in Germany. In fact, I think they referred it to us as part of their protocol. She had a pretty good job prior to all this, but she was forced to retire about 2 years in because she just didn't feel that she was capable of functioning and performing the tasks that are needed. So here we have our lateral flexion extension films again. Again, we can see here the lordosis of the cervical spine is okay, but when we go into flexion, we exceed our 18 degrees again, and we can see a little bit of stair stepping there, but not as much as the last one. And when we go into extension, again, we're going up above our 55 degrees, which would tend to imply hypermobility. And the other thing here we can notice is very slightly retroflex dens, which can create a little bit more crowding in the foramen magnum, around the foramen magnum, when this is present. Her clivaxial angle, which is the angle made from the lower third of the clivus here with the back of the C2 body, that should stay relatively consistent when you go from flexion to extension, and hers changed by more than 20 degrees on flexion extension, which is clinically significant. And also, again, her Harris measurement changed more than 2 millimeters, which suggests an element of craniocervical instability. Here is her upright MRI, or some of them. Again, we have crowding of the posterior fossa here with the cerebellar tonsils hanging a little bit low, dipping into the canal. And we can see this enhanced posterior emissary return pathway again. Outcomes. This one took a little longer to get her back on her feet. She responded steadily in the first few weeks, and as time went on, she got better and better. But at 4.5 months, which is where we took this from, she was no longer dizzy. Pretty much her cognition had come back to pre-injury status. She was now able to work at a laptop computer at a desk and function on complex tasks. She reported no neck pain or muscle weakness. Her fatigue, her chronic fatigue, had improved significantly to the point where she was able to do a lot more with increased energy. And if she fatigued herself, the thing that was most obvious to her was that she could go to bed and rest and wake up the next day and feel like she was able to go again. So her recovery was much better. She had taken up swimming and she was cycling again, and she reported that her breathing had more or less normalized, and she was doing much better. Julian said there were 3 case studies. I snuck an extra one in, sorry Julian, but again, this is a very similar ilk. This is a 36-year-old female, came to see me a couple of years ago, nearly a year and a half ago. She'd had a 10-month history of progressive pressure headaches, face, neck, back and shoulder pain, severe fatigue, muscle weakness. She was unable to be upright for any significant length of time. She came in wearing a hard collar. She came in with quite a few support members of her family that had helped her manage to get to the clinic. She'd come from a little way away. And severe cognitive dysfunction, unable to process very well, hypersensitive to sound and light stimuli or crowds. And something that we see not infrequently, when she lay down, that the pressure of the back of her head on a pillow or on the table would refer pain to the frontal region of the skull, the brow, the eyes, back of the eyes. And she reported that her mood was way off. She was irritable, and an element of anxiety or just being out of sorts. She had a diagnosis of HEDS, suspected CCI-AI and subaxial instability from previous scans. She'd also had some CT venography scans done, which had identified that she had reduced outflow of the right and left transverse sinuses, and also internal jugular vein narrowing, and a diagnosis of POTS. Here's her MRI. Slightly reduced clubaxial angle, but nothing terribly out of range. When she goes into flexion, we have 18.5, which would be upper limit of normal. When she goes into extension, she goes a little bit further than the 55. Again, here we have our cluboaxial angle going from 131 to 155. So that would tend to imply there's a bit of laxity there at the CCJ. And we have a Harris measurement, which goes beyond 2 millimeters. This is her in rotation. We can see with our right rotation, we've outlined the lateral masses here just to see how they compare on the body, on the superior articular surface of C2, and she stays on. She stays on quite nicely there. Still hanging on this one here, so she looks like she's a reasonable candidate for AO. What we do notice is that when she turns, you can see that the odontoid peg is migrating closer to the lateral mass when she turns her head left and right. So again, that would tend to imply an element of ligament laxity at the CCJ. 35 degrees is the upper limit of rotation. Again, we can see that's exceeded a little bit when we go to the right, and right at the limit of normal there when turning to the left. Slight counter rotation between C1 and C2 in the neutral position. And this one here is just to show you that there's quite a, it's not uncommon to see asymmetry of the joint surfaces here. So you can see here, this is the joint with COC1 on the right. Here it is on the left, and these are the axial surfaces here. These are not symmetrical vertically. So there's a slight height difference left to right. And again, we're going back to our posterior return pathway. We can see there's some quite large veins, or a quite large vein here draining off the skull, which we talked about a little bit last week, and possible mechanisms as to why that might occur. But it's interesting that you do tend to see this more frequently in patients that do have hypermobility. Lateral X-ray, congenital block vertebra. This one I put in here just to show you that there's an element of anteriority in the neutral. This is the cervical gravity line, which is about 17 millimeters anterior of the body of C7. Ideally, that line should be striking in the first 1/3 of that vertebral body, which tends to imply that the head is carrying slightly anterior. Again, this AP open mouth, we've got a little widening of the parodontine space, and the X-ray shows us quite nicely that offset, that asymmetry of the skull base there between those two articulations. Again, widening of the parodontine space. So what happened? After 2 weeks, she came back on her own without the cervical collar. She had come up on the train by herself. She was reporting that her general cognitive power and mood had improved significantly, that she had better energy. She was able to be upright significantly longer. She'd been driven up laying down the first time she came to the clinic, and her ability to tolerate stimuli, crowds, had improved to the point where she felt confident to take a train on her own. The pressure sensation when she was laying down, that persisted, but might have been slightly better at this stage. She had less pain, muscle pain, skeletal pain in the neck, back, and shoulders, and the POTS had not really altered very much at all. And she was at this time working with functional dentists, and she'd started the tenomandibular appliance therapy, which has been ongoing for a while. About 18 months later, in fact, this was just yesterday, she was back in, and that's why I put this slide in. So I think it's 18 months, or just short of 18 months. The pressure sensation when laying down has more or less resolved or improved significantly. Again, the neck and shoulder discomfort, the tolerance to being upright had improved. But the other thing of interest was that for the most part, the POTS signs and symptoms seem to be under control to a greater extent. So there's been a steady and progressive improvement over time, and she's managing that in coordination with the functional dental work, which Dr. Bishop's going to talk a bit more about next week. There we are. Questions?
Thank you very much indeed, Dr. Smith. Wonderful. Very, very interesting cases. I'll first of all go through questions that came in on the Q&A last week, some of them anyway, and then questions that we received post your talk, and then we'll go on to the ones in the Q&A that we have now. So if a suspected CCI AAI patient has a positive Babinski reflex, does this mean it's starting to damage the spinal cord?
Well, Babinski sign is an indicator of upper motor neuron lesions, so there is something going on. And again, in the context of clinical examination, you would have to look at a patient like that and see whether or not that was something you were going to manage. If you're having positive Babinski and it is a genuine, not a withdrawal reflex, then that obviously should be assessed by neurology to see what's going on.
Why wouldn't that show on a supine MRI, as presumably it didn't?
I'm sorry, I missed the question.
Why wouldn't that show on a supine MRI?
The Babinski reflex?
Well, I suppose the damage of the spinal cord.
Oh, okay. Yeah, I mean, to see something on an MRI, you need there's several factors. One of them is you need enough inflammation or damage to spot a lesion. You also need to be scanning using techniques that are looking for that type of lesion as well. So contrast scans. Again, this is getting a little bit out of my scope of practice, but and again, cervical myelopathy can be quite subtle if it is the cord that's being damaged, and it may not show up necessarily. So again, that would be something that we have this. How would I describe it? We have this perception that everything is scannable and that you can see it on an MRI or see it on a CT scan. And that's not always the case. There are lots of things that happen in the nervous system that are quite hard to image and may not show up. We had a good discussion on spinocerebellar tract involvement. And I've had these discussions with neurologists and neurosurgeons. And the big problem with spinocerebellar distortion, tensioning, is how do you demonstrate it? How do you test for it? Imaging-wise. And I haven't had a good answer on that one yet. So
thank you.
We see it clinically, but imaging it is not.
Not always imaging, yes.
No, not at the moment. Right.
This question came in many different varieties, which is basically how can people with intrinsically lax ligaments, in other words, HEDS, hold any adjustment that's made?
That's a good question. And if you look at those cases that we just presented, and the reason I presented those in London was to the group was because they're almost confounding to the problem is if you looked at all three of those well, four of them really, except for the 9-year-old boy, I don't think you'd find a neurosurgeon that would entertain the thought of fusing a child that age at this stage. But all of those would have met Henderson's criteria for CCI-AI, and there would have been justification. There certainly wouldn't have been the considered inappropriate to refer them for neurosurgical opinion. Now, those three cases, we had that discussion that we talked about the 4 plausible outcomes last week, and we sat them down and explained that, we have 4 outcomes. Outcome 1 is we make a correction and things go well and you feel better. Outcome 2 is that we make a correction and you might feel better for a little bit of time, and then we struggle to stabilize you. Now, that's therapeutic and diagnostic at the same time, in the respect that, 1, we make the correction and we can see a shift in the patient's symptomatology, and that tends to help us identify the CCJ as being an underlying mechanism for their presentation. But also, if the conservative management is failing to maintain correction, then it helps guide the decision-making process for whether or not this patient may be a suitable candidate for neurosurgical intervention. So, of those patients that we talked about just before, I mean, the last patient that we discussed, I adjusted her atlas the 1 time on her first correction, and from memory it held for about 11, 12 months, 13 months before it came out of correction again. And she's only been adjusted twice in nearly a year and a half. So again, we talked about this last week, about how the first articulation between the skull base and C1 is the seat of stability, in the pillar of stability in the spinal axis. It's not a joint that typically has a lot of movement to it anyway. So when it misaligns, it tends to misalign in a static fashion. When you go down to the next level, the second, first and second cervical vertebra, this is the seat of instability because it's the most mobile. Now, it depends a little bit on some of those factors of rotation. My concern for the patients where they over-rotate and there's no longer a visible overlap of C1 on C2, that they're possibly going to struggle a little bit, and that they're the ones that we talk to and we say, look, this is an option, a conservative option. If we start here, you'll either get better, you'll get better for a short period of time, and then we have problems. There'll be no change at all, or you can have an inflammatory response, and it might irritate the situation for a little while, but typically that sort of settles down to pre-intervention status relatively soon, as far as I know. So we had those discussions with the patients that we've just talked about, and they made the decision that they would rather start with a conservative intervention than going too aggressively too soon. As it turns out, they've all done really well. And as I say, the confounding part of the studies, those last 3 in particular, is that radiographically, they have the measurements that would suggest they're lax and unstable. They have diagnosis of some of them have diagnosis of HCDS, and yet they have done quite well. And it may be that you're offsetting something. Some patients, I think, they're a bit more problematic to manage. It may be that you're delaying more invasive procedures by doing this. But I had this discussion with some parents of 2 young ladies that had full cervical fusion, occiput to the upper thoracic spine, and as they pointed out, if you can delay it for 2 or 5 years, it's still worth doing that.
Yeah, thank you. And possibly working concurrently on infections could help from our discussion previous to this. I remember you, if I just ask that question and then you could perhaps give the answer to it, because sure. You mentioned in your presentation on CCI that Lyme disease damages ligaments and discs. Are there actually clinical observations to back this up, or are there any studies or written evidence? This was a question that came up last week as well, and you gave a fascinating answer to that after we'd spoken.
This question came up in Professor Smith's talk when he was asked, is there a connection between Lyme disease and ligament laxity? Does Lyme disease create lax ligaments? Was the question put to him. And his response was very sensible, I think, in the respect that, as he points out, that we do see, there does seem to be a correlation with patients that do have lax ligaments and Lyme disease. So there is possibly an inflammatory process with the Borrelia that does create degradation of tissue. The conversation that we had earlier was that coming from my side of the fence, education-wise, is we tend to view health as an inside-out prospect, in the respect that even in the current climate, where you're having a situation where there's a rather nasty virus running around, we would tend to view the susceptibility of the host as being the determining factor rather than exposure. And I think B.J. Palmer was one of the developers of this profession and something of a philosopher. I seem to remember one of his books saying something along the lines of, when you find a dead squirrel on the road and you turn it over and it's full of maggots, did the maggots kill the squirrel? Essentially, the tissue that's susceptible to external influence will be broken down and invaded, so that the sort of off-the-cuff remark we had before we did this today was, does Borrelia cause ligament laxity, or does Borrelia find a good home in lax ligaments to start with because they're susceptible already? That's just conjecture.
Thank you. Another question that came up several times was, what hard cervical collar would you recommend for AAI?
There are several different ones out there. I'm a little bit reluctant to make too many recommendations based on that. These are the sorts of conversations you should have with your neurosurgeon. If you've been diagnosed with AAI and you've been told to wear a hard collar, they would have made a recommendation for you. The thing that I have to be a little bit wary of in this kind of setting is to be misinterpreted as giving clinical advice to an individual.
I understand. It probably needs to be very tailored, doesn't it?
It does. Needs to be very generic and non-specific, and I'm not evading a question, but there are a couple of collars out there, Aspen, Miami. There are a few different ones, different settings. But again, these things should be applied under supervision of the physician that's diagnosed the CCI-AAI and follow their recommendation.
Thank you. Are there resources that we can show NHS professionals to get the right imaging done and avoid an FND diagnosis? When I say FND diagnosis, that's basically somatizing it. Yeah.
It's a big problem. Somatization is as we talked about last week. If you present with a whole list of signs and symptoms that are associated with Craniocervical syndrome, cervicomedullary syndrome, at times you're going to hit some resistance with that. And something I've noticed over the years is when you have patients that have been around the mill a few times, they come in and when you're taking a case history from them, they're actually quite reserved about what they tell you, so some of them. And after a while, you understand, or you get the impression that they've had multiple bad experiences with physicians, and they actually are defensive and not really forthcoming as you'd like them to be, because they're afraid that you won't believe them. And that, that's a very unfortunate situation. So as far as imaging goes, the imaging parameters are somewhat accepted as far as I can tell. It's finding somebody who is prepared to take the images appropriately, as Professor Smith talked about in his presentation. If you don't look for it, you won't find it. It's that simple. And the vast majority of CCJ imaging that's done around the world, not just here, is insufficient. It doesn't cover the region properly. So
Yeah.
you have to find an imaging centre that can do the imaging, and then somebody who's prepared to interpret them properly.
It's huge, isn't it? Yeah.
Yeah.
I'll go on to some of the questions that have been asked today, even though I do have more here, which is, are there any neck exercises that an individual can do to help increase blood flow to the brain?
Well, again, that's a little bit of a generic question. I mean, we do have some patients that we are very careful about what exercises we recommend they do, simply because of the anatomy of their brainstem and their spinal system. Some patients that come through here, we recommend a cervical pillow. Others, we recommend they stay away from a cervical pillow, simply because of the anatomy is just not conducive to having the neck in extensions. So that's a case-by-case basis and assessment. I'd be a little reluctant to give a generic answer to that.
Yeah.
Unfortunately.
Would you say the same to another question that came in, which is, do you have any suggestions on how we can strengthen the muscles and ligaments of the whole neck area?
I've got some good suggestions, but again, that's on a case-by-case basis. You have to be a little bit wary about what you do. You can, experience has taught me that you can place one patient's head in a certain position, which is passive and seems quite innocuous, and they'll be fine, and someone else you put them in the same position just to see how they move, and it can make them feel very unwell. So
thank you. Yeah.
Assess them as you go.
Yeah. Another question here. Most chiropractors know and use these neck adjustments.
Atlas orthogonal. No.
I think probably your answer will be no. It's a specialist training, right?
It's a particular technique. At the moment, I believe we're the only clinic in the UK that's performing the AO procedure. That doesn't mean there aren't doctors out there that have done some training in AO, but for whatever reason they're not utilising the system. At the moment, my understanding is there's the clinic here in Newport, there's one in Cologne in Germany, Barcelona and Milan, and then it's Dubai and Abu Dhabi or New York.
Oh my goodness, okay.
At this point.
What percentage of patients would you say resolve their ME/CFS with Atlas orthogonal treatment? It's probably a very difficult question, isn't it? But do you have some sense of that? I mean, these diagnoses, ME and CFS are very general anyway, aren't they, in many cases?
Yeah, I think the challenge with these sorts of cases, there's a lot of factors involved in that. Some of the cases in this presentation here would have been qualified as chronic fatigue. In fact, more or less the last three, I suspect, would have potentially qualified for that. The last three cases are patients that all live within, driving distance or relatively easy traveling distance to the clinic. So they're an hour or so away at most. One of them literally lived 1.5 miles down the road. So for her, that worked out very well. It's the follow-up management that is an issue. So logistics is always part of the equation, and of course we have patients that come from all over Europe and Scandinavia, I suppose, the Mediterranean, things like that, Middle East even. They are far more challenging. So it's more than just whether or not you get your atlas adjusted or have your cranials done, or your teeth sorted, or all of those things. There's also the follow-up management that plays a role in this. And I think if you have chronic fatigue as is described, and it's that severe, then it's more than just an atlas situation. There's going to be underlying issues with.
Oh, so you're going to be working integratively, aren't you, with other therapists as well?
Exactly, and a lot of it depends on what the patient is actually engaging with outside of this clinic too. So I really don't have a good answer to that. I'm sorry. I wish I could.
Understand? No. Another question relating to follow-up there is how often patients normally see you for maintenance?
It's a bit case by case. If you're living in Birmingham, you might make the decision to come a little bit more often. If you're flying in from Israel, that's a different story. We try and be as flexible as we can. People need to take into consideration their logistics, and their particular cases. But typically, I think for most, if they're stabilizing and doing reasonably well, a checkup a couple of times a year, 2-3 times a year, maybe 4. Had some horror cases over the years. There's one gentleman who came in here for quite some time. He had some very long history of problems after an assault. He'd unfortunately had some started and then the physician stopped practicing, and it all kind of went south. And he spent a lot of time in my clinic, and eventually, though, he managed to get his teeth sorted out, and it made a significant difference to him. So, yeah.
Oh, thank you. Yes. Several people have asked a question that I know is probably going to be very difficult to answer in the time, but I'll try anyway to pose it, which is, are you able to explain the adjustments that you actually do, and the way in which you sort of advance from the cases that you presented to the outcomes? Is that very, very complex, or are you able to give a sort of outline view of what they consist of?
Sure. Well, I'll do my best. Obviously, it's going to vary from patient to patient, depending on a lot of things. But in the less complex circumstance, typically patients come in, we assess them, and we determine whether we think atlas orthogonal is appropriate for them. If we do, then we take some images, and we may need to order additional images if they don't have, if it's not complete enough. But then the first thing we do is we'll make a correction to the atlas on the predetermined vectors. And if you remember last week, there was a picture of a young man from Norway, side lying on the table with that instrument that had been set up very specifically. It's calibrated in single degrees on an orthogonal concept, and the imaging, it's an image guided procedure. Now, it looks kind of scary. I had a couple of young boys in here the other week. One of them had fallen on his head from a climbing frame in the playground or something or other, and 2 brothers. And he wasn't an orthogonal patient. His mother had brought him in to try and sort out some problems, but they were both there doing rock, paper, scissors to see who was going to go first, because they didn't like the look of that machine at all. They thought they were going to get an injection of some sort, which we had to explain to them they weren't. But that metal stylus is essentially, if you can imagine, it's a specific density of steel, and behind it is a hammer on a solenoid. So the hammer hits the back of the that stylus, the stylus doesn't move, it vibrates. So it's a compression wave. It works on that principle of the, what do they call those, perpetual motion balls. You know, when you hit this object, the inertia is transferred, the force is transferred in a compression wave into the stylus. Now, as long as that is in proximity, this is quite awkward to do this, isn't it? Trying to make this happen. As long as that is in proximity to the soft tissue of the neck, that force is translated through the fluid, cellular fluid itself, or the tissue, and you'll create enough inertia if the patient is set up properly and your angles are spot on. If you're not, then you just won't move it. It's only 25 newtons on average of force, which is very small. And again, it's a bit like trying to push a marble over a hill. If I get the marble to there and I tap it, it'll roll up and roll back down again. If I get it to that tipping point, I tap it, it'll roll over the other side. So it's a very subtle, very, very subtle.
Are there any risks associated with that, which was another question, or is it simply if it hasn't worked, then you're sort of back to where you were, but nothing can go wrong, really?
Well, you can never say never for anything. There are, as far as I'm aware, there's no serious adverse event that's been recorded with the AO intervention, and Dr. Sweat developed this instrument in the late 60s.
Wow.
So it's been in use for 50 odd years now.
Wow, that's quite a statement.
Yeah, so that doesn't mean that people don't necessarily generate neck pain or headaches, or they may have, radiculopathy into the shoulders or arms or something or other. But that can happen. Unfortunately, it's not a common thing. But and headache, of course. But as far as I'm aware, there's not been any recorded incident of arterial dissection or anything like that.
Thank you. I imagine there's a lot more to explain regarding the adjustment, but probably patients would need to find that out on a patient-by-patient basis. But there is one follow-up to that, which is, how would you assess that a patient is holding an adjustment? Do you measure this effectively using radiographs, or subjectively assessing their symptoms?
Yeah, typically on the first correction, you'll take a pre-X-ray that gives you the vectors for the correction. You make a correction. When you're looking at the patient, as we talked about in the physical exam I briefly touched on last week, you're scanning the neck for tenderness over the dorsal roots of C1 and C2, and they'll typically have a pattern that's unique to them. So when the atlas misaligns, if you look at some of those pictures we just viewed on those cases, the shape and design of the skull base and the upper cervical spine will tend to predicate that the atlas will move in a particular direction. And that's relatively consistent for most people. Not everybody, but for most people, it's reasonably consistent. So when the patient presents as being out of correction, they'll typically have tenderness in the upper cervical spine that's palpable. For the most part, people will have a tendency towards a leg length discrepancy. It's usually consistent again. They're the clinical indicators you would look for on a routine visit. And you would look at those in the first assessment. You would check them on the first day, and then you check them on the second day before you make your first correction. And then after the correction, they should clear. Those parameters should have resolved or improved significantly. And then you take your post X-ray. Your post X-ray should show some improvement in the measurements. And as long as you're satisfied with that, and it may be that you need to make another correction, slightly modify it, and take a post X-ray. Sometimes that happens. Not always. Sometimes. Then you have a pre-indicator, you've got radiographic evidence that you've made an improvement, and you've got post-indications have cleared. Patient comes in 6 months' time and their right leg's short again, and they've got tenderness over C1 again. then you would look at that and say, well, this patient's probably not holding correction. You need to check and make sure there's not something else going on. But if the indicators are there, then you would adjust that patient on the vectors that you calculated the first time, because they were proven to be effective. Now, that can change. If you come off a motorcycle and hit a tree, or fall down a flight of stairs, or fall off your horse, or unfortunate enough to get physically assaulted or something like that, it may be that in some cases you would reassess that. You would certainly reassess that if you had started to adjust the patient and they just all of a sudden stopped holding their correction and were becoming symptomatic again. You would definitely want to reassess that. But for the most part, no. The listing is usually quite unique to us. For example, my upper cervical listing hasn't changed in 20 odd years.
Okay, thank you. Well, quite a few more specific questions are coming in, like whether you could list the similar clinics that you've mentioned. So I'll ask you about that separately. There's somebody from America here who would like to specifically know the New York one. Someone else,
There's a lot of doctors in the US, but if you're in New York State, you want to go and see Dr. Rosa, would be my recommendation.
I'll ask you for the link to that afterwards, maybe, and send it to that person who's made the request. And then someone else asking whether you'd be prepared to work with a particular university to train up the chiropractors in this area. So that would be, a fascinating further, thought that I'll simply send on to you. Could I please ask you a question that actually links up to our next webinar with Dr. Bishop next week, which is last question really, because we are running over time now. If the bite occlusion is a problem and the bite is corrected by a dentist, can correcting the bite cause the alignment of the atlas to move into correct alignment without the need for a chiropractic atlas adjustment?
I would say yes. That does happen. And where I would kind of dance around this a little bit is that it's not always that straightforward. But the thing that I found by combining upper cervical technique with an understanding of craniopathy and craniofacial constructs is that you can have a lot of crossover, and I tend to make the analogy that the atlas and the jaw is like a hand and a glove. You can't separate the two. When the fingers move, the glove moves. Okay, so what's happening here in the stomatognathic apparatus has a tremendous influence on the muscle patterns and head or neck patterns in the upper cervical spine. Something as seemingly innocuous as an aberrant swallowing reflex. If you remember the first little boy in the series that we just talked about, he had a congenitally short frenulum, which is the bit of tissue under your tongue here, which prevents you from swallowing properly. Well, that repetitive stress of swallowing, which we would probably do 2,000-3,000 times a day, is constantly pulling on the superior pharyngeal constrictor, which is the muscle at the top of the back of the throat there that initiates moving the bolus down the gullet. But that has fascial connection to C1 and C2. So if I have something as seemingly unrelated as an issue with my mechanism of swallowing, I'm constantly stressing that upper cervical spine. If the TMJ or the jaw or the bite planes start to have issues, or the congenitally haven't formed well, or dare I say, iatrogenically they've been modified, this can have a significant impact on the upper cervical spine. And I think I said this last week, some patients come to me wanting a magic bullet. And, I assess their situation and determine that we're on a road to a hiding unless we get your teeth sorted out. And that's when we call in Dr. Bishop, who's going to hopefully give you a very interesting presentation next week.
Thank you very much indeed. Yes, definitely. He'll be on next week, and it is the 10th of February, and he'll be speaking at 7 o'clock, same time. I can tell Dr. Smith that we're probably going to need to have you on again, because I haven't managed to get through any of the lists of questions I had, whether today's or the ones I had from last week. So hopefully there'll be an opportunity for that again. But for now, thank you very, very much indeed. That was all, amazing information, and I'm sure it'll be very, very helpful to everybody who's listened. Thank you, everybody, for being there. And do continue to send in questions, because I'm quite sure if you're all right with that, Iain, we'll have you on again. Thank you. Thank you very much.
Very well, everybody.
Okay. Thank you. Goodbye. Bye, everyone. Thank you.